All right. Thank you everyone for joining our webinar series once again. I'm Dr. Shin, and for those who I haven't had the chance to meet yet, I'm part of the team here at the Sklar Center. I focus on hormones, skin, and digestive health and pediatric care. Just a quick note before we start, if you have any questions or comments while we go through the slides, you're welcome to drop them in the chat or you can hold them until the end. We'll make sure to go over everything at the end. And today, we'll walk through what actually happens hormonally during menopause and andropause and why symptoms can look so different from person to person. We'll focus on estrogen, progesterone, testosterone, and adrenal hormones, how they interact, and how we safely support them using evidence-based bioidentical hormone therapy. We'll also review labs, monitoring, and clear up some common myth around hormone replacement. And at the end of the slides, we'll also go over a patient case. All right, so just a quick estrogen and explanations. So there are three main estrogens in the body: estradiol, estrone, and estriol. Estradiol is the most potent and biologically active. Estriol is the weakest and often discussed as more gentle, while estrone, it becomes a dominant estrogen after menopause. So these estrogens are not static, meaning the body is always converting between them depending on enzymes, tissues, and metabolic health. After menopause, the ovaries are no longer the primary source of estrogen. Instead, estrogen is produced through conversion of adrenal androgens in fat tissue. So this means that body composition, adrenal health, and enzyme activity all influence estrogen levels even years after menopause. And estradiol does much more than just regulate reproduction. It plays a critical role in bone density, insulin sensitivity, brain health, mood, sleep, skin, vaginal tissue, and cardiovascular protection. But we do have to make sure that estradiol is always balanced. So too much or too little estrogen without progesterone can increase risks such as abnormal bleeding or endometrial cancer. And some of the low estrogen symptoms. So low estradiol is one of the most common drivers of menopausal symptoms. So hot flashes and night sweats are the most classic symptoms that we see in postmenopausal or during menopause. But low estrogen also affects joint, skin, mood, cognition, vaginal health, and cardiovascular risk. And many women don't realize how systemic estrogen's role truly is. So low estradiol isn't always just because of menopause. It can be worsened by poor adrenal output, extremely low body fat, very low cholesterol level, mitochondrial dysfunction, or even excessive use of supplements like DIM. This is why we always make sure we have an individualized, more personal assessment before we start any HRT. And sometimes postmenopausal women with higher estrogen levels, they can still feel estrogen deficient. And these symptoms depend on receptor sensitivity, metabolism, and progesterone balance. So in women on estrogen therapy and HRT, excess estradiol can sometimes cause breast tenderness, bloating, headaches, and abnormal bleeding. So we always make sure we go over symptoms every visit. And long-term estrogen deficiency, it actually contributes to major chronic conditions, including cardiovascular disease, osteoporosis, insulin resistance, neurocognitive decline, and muscle loss. And so hormones aren't just about symptoms, they actually influence more long-term health trajectories. And the idea that all menopausal women are estrogen dominant is largely a myth that we often hear. So in perimenopause, progesterone will actually drop first and estrogen will fluctuate. And during menopause, estrogen becomes deficient and also be exposed. exposure to xenoestrogens. So these are commonly found in environmental toxins, microplastics, and also having poor metabolism, they can still all create that imbalance. Progesterone. So progesterone is metabolized into compounds that influence the brain. So there are two metabolites of progesterone. One is alpha pregnenolone, in which that helps support the GABA activity, promoting calm and sleep. And there's also beta pregnenolone, which is an inactive form that's used for more measurements and ratio calculations. So this explains why progesterone overall helps with anxiety and sleep. And oops, before we do that, I also wanted to go over that progesterone supports sleep, mood, cognition, and bone health. And also, it protects the uterine lining when estrogen is used. This is why we always prescribe progesterone with estrogen, especially for women with uterus. And and we also want to go over how progesterone is closely tied to stress physiology. So the adrenal glands produce progesterone in response to stress, which means chronic stress can disrupt progesterone balance and worsen symptoms like insomnia and anxiety. And after menopause, progesterone is no longer produced by ovulation. Instead, it comes almost entirely from the adrenal glands, which is why adrenal health is a key factor in progesterone health. So low progesterone often presents as poor sleep, anxiety, irritability, fatigue, and weight gain. And the most common cause of low progesterone, as we talked about in the previous slide, is probably the adrenal dysfunction due to chronic stress. And so we really want to support that using bioidentical progesterone, stress reduction, sleep optimization, and adrenal adaptogens. And sometimes having too much progesterone can also cause symptoms such as fatigue, mood changes, bloating, and breast tenderness. So we really want to make sure that we give the proper dosing for each individuals. And testosterone in postmenopausal females. Testosterone is equally important for women. It supports muscle mass, bone density, energy, mood, libido, cognition, and cardiovascular health. And it also serves as a precursor for estradiol production, meaning it helps produce estrogen. And so testosterone usually peaks in early adulthood and gradually declines with age. And after menopause, most testosterone comes from adrenal and peripheral conversion rather than ovarian production. And usually, low testosterone often shows up as fatigue, muscle loss, weight gain, brain fog, low libido, and sexual dysfunction. And these symptoms are frequently overlooked or misattributed. So common causes include aging, having adrenal dysfunction, thyroid issues, diabetes, nutritional deficiencies, excessive exercise, undereating, and endocrine disrupting chemicals. And when there's too much testosterone, it can actually cause acne, oily skin, increased hair growth, scalp thinning, and mood changes. So we always want to make sure that we're not giving too much testosterone. Andropause. So andropause is something that men go through as they also experience hormonal changes as they age. And so this is also called the menopause. And unlike menopause that women go through, this process is more gradual and it's not as sudden. And it usually often goes unnoticed for years. As testosterone levels decline, some men will develop what's sometimes referred to as grouchy old man syndrome. While women often experience more depression and anxiety with hormone changes, men tend to express low testosterone as increased irritability, anger, and frustration. And starting around age 30, men will lose approximately 1 to 3% of their testosterone each year. And a small percentage of men even have low testosterone in their 20s. By age 30 and beyond, about 20 to 30% of men have low testosterone, and by age 60, nearly half of men are affected. And so low testosterone impacts overall well-being in many ways, including low energy, endurance, athletic performance, muscle mass, libido, sexual function, mood, and cognitive clarity. And many of these symptoms overlap significantly with what women experience during menopause. And testosterone is also critically important for brain health. In men, lower testosterone levels have been correlated with an increased risk of Alzheimer's disease. And studies show that testosterone therapy can actually help improve memory and cognition in some men. And interestingly, some testosterone in both men and women is converted into estrogen, and we knew that. So this small amount of estrogen actually can have testosterone's protective effects, particularly for brain function and cardiovascular health, since estrogen supports that healthy blood vessels and arteries. And so really the key takeaway is that hormone balance matters for both men and women, and age-related hormone decline can significantly affect quality of life when left unaddressed. All right, so the bioidentical hormones, so what they are is that they are identical to, very structurally identical to what the body actually produces. And bioidentical hormone replacement therapy include estradiol, progesterone, testosterone, DHEA. DHEA is an adrenal gland hormone that helps make testosterone, but also play a role in our energy level, and pregnenolone, which is a mother hormone that helps make testosterone and progesterone. And so these are prescribed based on symptoms, lab results, and risk profile. And so benefits for bioidentical hormone replacement therapy include symptom relief, so hot flash, night sweats, irritability, sleep, low libido, and energy. And it also has bone and cardiovascular protection and overall improved quality of life. So the risk really depends on dose, route, timing, and monitoring, and your personal and family health history, which is why personalized care is really important when we are prescribing bioidentical hormones. So there are many misconceptions around hormone replacement therapy, especially the belief that hormones are inherently dangerous or that they universally cause cancer. So in reality, hormones are powerful in that their safety really depends on the type of hormones, the dose, the route of administration, timing, and monitoring. And bioidentical hormone replacement therapy uses hormones that are structurally identical to what the human body naturally produces. So when prescribed, the HRT therapy can be actually both safe and highly effective. It's that when the problems arise, when therapy is not individualized or when we're not continuously monitoring the patients. And one of the key principal route is route of administration. And so we really prefer transdermal estrogen, so using patches, gels, or cream, just because it bypasses the liver metabolism and has a lower impact on clotting factors. And so the oral estrogen, whether it's bioidentical or not, it actually goes through the liver and can increase the risk of blood clots, strokes, and heart attacks.
Ah.
So if a patient can't tolerate transdermal or topical estrogen, oral estrogen can be used, but it's done very cautiously with appropriate lab monitoring and clotting risk. So the most important takeaway is that hormone therapy is not a one size fits all. Individualized dosing, proper hormone selection, careful monitoring, and shared decision making are what makes this modern hormone therapy really safe and effective. Okay. And continuing on with the benefits of HRT. So this is one of the study done by Eugene Kim. And so this study actually included 379,352 women. So it's a large study. And the researchers found that women who used menopausal hormone therapy had a 58% lower risk of developing neurodegenerative disease overall. So this included Alzheimer's disease, ALS, which is Lou Gehrig's disease, multiple sclerosis, and Parkinson's disease. So these results really support what we know about estrogen's role in brain health. And estrogen helps protect neurons, reduce inflammation, support mitochondrial function, and maintain healthy blood flow to the brain. So this doesn't mean that hormone therapy is for everyone, but it really just reinforced the idea that hormone therapy, using the right hormones at the right dose at the right time with appropriate monitoring, really potentially can have long-term brain health benefits. And when we talk about estrogen therapy, it's really important that we distinguish the bioidentical estrogens from synthetic or non-bioidentical options like Premarin. So Premarin is it's actually derived from pregnant horse urine. So that's something that conventional doctors will often prescribe. So bioidentical estrogens such as estradiol and estriol has a similar or same molecular structure identical to our body naturally produces. And because of this, it tends to be better tolerated and safer for many patients. And bioidentical estrogen actually has not been shown to increase clotting risk as long as it's used transdermally, so through a patch and cream and gel. And they may actually offer protective benefits for cardiovascular health, including reduced risk of heart attack and stroke. And it also has a neuroprotective effects like we just talked about. In contrast, though, the Premarin that has been associated with increased clotting risk, as well as higher rates of heart attacks and strokes, especially in older women. So these vascular events can then contribute to an increased risk of dementia related to stroke. And even though it didn't have an increased risk of breast cancer in larger trials, its overall risk profile, particularly for cardiovascular and neurologic outcome, is the reason why we avoid using Premarin. And really, the key takeaway here is that not all estrogen is the same, and the type of estrogen really matters when we are weighing the risk versus benefits, especially as women age. And just like estrogen, progesterone is not one size fits all. We really want to use the bioidentical progesterone versus a synthetic progestin because of following reasons. So the bioidentical progesterone is chemically identical to what our body naturally produces, and it's been actually shown to inhibit breast cell growth, and it does not increase breast cancer risk even when used in combination with estrogen. So in fact, when paired with estrogen, it actually helps protect against heart attack and stroke rather than increasing that cardiovascular risk. And bioidentical progesterone also can have a favorable metabolic effect. So it can increase HDL, our good cholesterol, by about 9%. And it doesn't really increase the diabetes risk. So many patients notice neurologic benefits when they use progesterone just because it has that calming agent, and it also supports sleep, mood, and anxiety regulation. Whereas the progestin, which is a synthetic compound, it's mainly designed to mimic progesterone, but they behave very differently in the body. So progestin can actually stimulate breast cell growth, and when combined with estrogen, they're associated with increased risk of breast cancer. And they also raise risk of heart attack and stroke, which is a major finding in large hormone therapy trials. And so you just on like metabolic and neurologic standpoint, progestins can be very problematic, and they can actually double insulin resistance and increase diabetes risk, and commonly cause a lot of emotional irritability and mood changes as side effects. So the hormone therapy we already talked about requires a lot of or continuous monitoring. So that's why we really check quarterly to see how you're doing, and adjust it based on your lab results and your actual symptoms. And so we really assess sex hormones, adrenal function, thyroid health, iron status, and anemia, just because most of these symptoms can overlap. So we want to make sure we're not misdiagnosing. And we also want to also aim for optimal and not just normal ranges. So So that starting the HRT earlier actually has shown to have more protective benefits. Mhm. All right. And we also order a Dutch complete test, which is a urine test that looks for hormone metabolites. And so this gives us an insight into detoxification, tissue exposure, and therapy effectiveness. And we really want to make sure that estrogen is being metabolized in a more protective pathways rather than the potentially harmful pathways. And so this actually helps personalize the therapy even more. All right, so this is one of the case study. So I will stop recording. So a lot of the key takeaways for the menopause is that the symptoms are multifactorial, meaning hormone deficiencies can be a key driver, but adrenal stress can also play a significant role. And normal testosterone levels can happen, but it doesn't really rule out any hormone-related symptoms. And addressing cortisol and stress physiology is really important for full symptom improvement. And really, the most important case or the most important part is that individualized, closely monitor HRT approach combined with supportive care is the best way when it comes to patient success stories. So, what are some things that we can do to really optimize hormone replacement therapy? So, first, reducing exposure to endocrine disrupting chemical is key. These are commonly found in personal care products, cleaning supplies, pesticide, and even microplastics. And choosing fragrance-free or cleaner products, avoiding plastics when possible, and choosing organic produce can also significantly lower hormone disruption. And second, stress management is very, very crucial. Chronic stress directly impacts the hormone signaling and cortisol levels. And so simple, consistent practices like mindfulness, yoga, journaling, regular movement, and spending time in nature can really help calm the nervous system and improve that hormonal resilience. And lastly, we do want to focus on nutrition because nutrition also plays a huge role in hormone detoxification. Eating whole, nutrient-dense food that supports the liver, so a lot of cruciferous vegetables that are responsible for clearing excess hormones, and antioxidant-rich foods such as berries and leafy greens, and fiber-rich foods to help bind and eliminate those hormones through the gut. All right. So thank you so much, everyone, for joining us today. And this webinar will actually be posted on our website at scholarcenter.com, so you can rewatch it or share it with people you know. And our next webinar will be held on the first Tuesday of February at 4 p.m. And I'll be covering the metabolic health and weight optimization, and we'll send out the registration email soon. I'll go ahead and stop recording so we can